patient with drug intoxication that I received at the emergency care. And finally, the patient ended up with a brain death. Patient, I think 25-year-old male that was found in his room unconscious and was rushed into the hospital. And upon quick evaluation, we realized that the patient had intoxication of opioid and was already going into a cardiac arrest.
The triage process, which is divided into the emergency patients, the urgent patients, and the non-urgent patients. So in a case where we have a road traffic accident, they always identify the leader of the bike riders. So we tell him to contain the population so that we can work on them.
Our oath to some patients is best, not usually the carers.
The challenges that we face in managing those emergencies are.
For resources, I want to divide it into human and material resources. Our biggest challenge we have usually in our setting is for us health personnel to be able to suppress our emotions when there's an emergency and actually give what is expected from us, because
Hello everyone, welcome to another episode of Africa Health Insight. In today's episode, we shall be discussing issues related to emergency management in less resource settings. As usual, we would like to hear from you on the comment section areas that need improvement. We would like to know from you some of the issues that you want us to discuss in our subsequent editions. In today's episode, I have with me, please can you introduce yourself?
Clinton, an emergency care physician and medical doctor.
And to my right, I have
Detail my emergency care name.
Okay, thank you and welcome to Africa Health Insight. Can you share with us an experience you've had recently managing an emergency in your setting?
Thank you very much, Elvis, for having me in this platform. I think that this is a great initiative that you have given us health workers to express our needs. I can remember a case we had for a patient with drug intoxication that I received at the emergency care. And finally, the patient ended up with a brain death, a situation that we could rescue, but because of limited resources, both human and equipment resources, we had our consequences, and it was so emotional for us.
There's an episode where we discuss drug abuse in our communities, and you've mentioned a case of drug intoxication. Can you just tell us some of the challenges you had in managing this particular emergency?
Okay, this is a patient, I think 25-year-old male that was found in his room unconscious and was rushed into the hospital. And upon quick evaluation, we realized that the patient had intoxication of opioid and was already going into a cardiac arrest. So first, it was a strange idea with the personnel we have. Some they were not very aware of the procedures for the CPR. So before I was called, I came down. The patient was already in a very critical state. So we had to start the emergency care where we requested CPR and intubation. And first, we did not have the skilled personnel to intubate the patient, and we tend to the lesser means which to provide the patient oxygen, and then we did not have an adult nasal pump. When we also requested for an ambu bag, we did not have an adult size ambu bag. So that delayed oxygenation to the patient, and we ended up with a brain death.
To my right, I have Ditelma, who is also having a vast experience in leading the teams during emergencies. So what are some of those issues you have communicating with your team, communicating with the patient and with the loved ones? How do you communicate with this multidisciplinarity?
To communicate with them, we have a process that is being designed, a triage process, which is divided into the emergency patients, the urgent patients, and the non-urgent patients. So you have to talk the carers throughout the process to make them understand that if your patient doesn't fall within the emergency case and the patient falls within non-urgent, the patient will be managed as the last patient.
Managing patients, it becomes like a crazy scene because you have everyone in the scene and sometimes you don't even know who is a patient, who is not the patient. So how do you manage some of those situations?
In those situations, if we could, we usually make sure to identify the group leader. For example, in a case where we have a road traffic accident,
Yes.
they always identify the leader of the bike riders. So we tell him to contain the population so that we can work on them. For the other means, we try to lock doors and lock windows and work with the patients in the emergency room.
Yeah. You have pressure in trying to attend to the patient, and at the same time, there are demands or there are unrealistic demands by the loved ones. Have you had that type of an experience, and how did you come up?
So I think it's a skill that we have developed over the years, considering that our population is not very informed. So what happens is we identify usually the leader of the gathering, try to explain the situation of and the needs of the patient and encourage them to share this information with the others, try to set some order, then while we cater for the needs of the patient. We always try to be dynamic because most of the times if we don't explain to them the situation of the patient, it creates more chaos and they may not be able to collaborate or cooperate or they may misunderstand some of our interventions, and if anything goes wrong without explaining, you may not be able to adjust at that level.
Have you had situations where you had to make difficult decisions, and how did you come across those situations?
Our oath is our patient is best, not usually the carers. For example, a patient is unconscious, then probably the patient needs an oxygenated space, and carers want to force themselves in. It would compromise the concentration of the oxygen in the atmosphere. So we at times need to take some very harsh decisions, calling security to intervene and create some order for the good of the patient, because at the end of the day, if the carers notice that all these decisions is for the good of the patient, of course, they will understand.
Okay. I see you are nodding your head, Thelma. What are some of those challenges you've come across in managing emergencies?
The challenges that we face in managing those emergencies are lack of resources. Most of the times we lack resources to manage these cases. And then another point is the means of transportation. At times it's very difficult to transport these cases. You call to get on the ambulance is a problem, the ambulance coming and the nature too of the roads. We have very bad roads. I think and those roads can further compromise the patient's condition. And they can even take a longer time, like 2 hours before they reach the next point of care.
What are some of those resources you need in an emergency to be able to manage an emergency situation in our context?
For resources, I want to divide it into human and material resources. The community orientation to even identify the emergency and to give first aid. So I think that's a very key aspect for us. For example, in an accident scene or in case of a patient bleeding, they may not take some measures to maybe reduce the bleeding before they come, and when they come, it becomes difficult for us. So I will want that we look at the human aspect first from the community.
Okay.
Then in the hospital, usually it's difficult because we know especially the physician to patient ratio is quite low.
Exactly.
So at times we always need an assistant to identify, then before give a feedback to us and we respond.
Okay.
So we always have that difficulty as medical doctors where the persons in which we put usually the nurses at the emergencies, they usually don't identify these cases early, or even when they give the feedback to us, they don't give it in a way in which to request an adequate response. Yes, so usually even if we come as a very skilled personnel, maybe it's already late. Before we go to the equipment resources, where usually I realize that our facilities are not emergency oriented. I don't know whether because in Africa we tend to accept things are very complicated.
Exactly.
Yes, so we don't usually prepare to give life to those cases that are near death, to bring them back to life. So you may be in a case where you need some emergency equipment, you don't have them available. She talked about transportation. We all know how difficult it is for transportation. And another key aspect is in collaboration and communication between the facilities and even personnel. Like we have a higher facility where even when we send patients, they have a slow response in receiving these patients and attending to them. And we also have a slow response, even giving us feedback on how we could improve for subsequent patients. I think all this play to give us a difficult terrain for us to work and give care and participation.
You mentioned human resources. I don't know, are there some skills that you think Thelma, our nurses, they need in order to attend effectively to emergencies? And what are some of those skills?
They need to be able to multitask. You have to be assertive, you have to be dexterous, and you have to be critical. You have to be critical in handling those emergencies.
Okay. So if you were to recommend some skills for our healthcare teams, what do you think we should do further to be able to meet up to the skills of this personnel?
Our biggest challenge we have usually in our setting is for us health personnel to be able to suppress our emotions when there's an emergency and actually give what is expected from us, because usually at times we play emotional even with the carers and we don't give what we're supposed to give, or at times we shy away from actively involving, so that if it turns sad, we should not be blamed. It's great encouragement that when we have an emergency, even the basics of information that we know, we should be able to suppress our emotions so that we can offer these basics. We could go as much as saving the patient's life. For example, if a patient is bleeding and there's a crowd, you have to brave the odds to go and let them know that you could do this thing and you do, and you could save the patient's life. So that's a recommendation.
Okay, so once more, thank you. Thank you for coming. It's a pleasure to have the two of you share your insights and experiences with us. We will always come to you because we know you have rich experiences managing patients with low resources. So we are glad to have you, and I hope our audience they enjoy the discussions. So remember to share with us your own experiences from your own settings, how you manage your emergencies, some of the challenges that you have managing these emergencies. So once more, thank you guys for coming.